We have 3 representatives from UMass joining us via WebEx. If you guys could introduce yourselves, I know you want to make some opening comments, which will be limited. We'll limit those to 10 minutes, and then we'll open it up for questions. So thank you all for being here.
Well, thank you. We'll go in order on this, as presented on the slide. This is David Polikoff speaking. I led the TCPI team. I'm an internist and geriatrician by background, and a professor of population and quantitative health sciences at the University of Massachusetts Medical School.
And I'm Clifford Scott. I'm an optometrist and a consultant to the UMass Medical School, and president emeritus of the New England College of Optometry.
I'm Jay Flanagan. I was the program director for the TCPI project under Dr. Polikoff.
Welcome. You guys want to start with your opening remarks?
Thank you. This is David Polikoff, and I'll deliver the opening remarks, but we will all as a team be available to the PTAC for questions. First, I want to thank PTAC for hosting us and offering us this opportunity to present, and as well as express our gratitude and appreciation to the PRT for the very careful review and the process we went through during the PRT review. It was helpful and very, very thoughtful. So, by way of background, in 2015, UMass was awarded one of the 29 practice transformation networks by CMMI under its Transforming Clinical Practices Initiative, or TCPI. The goals were to promote a broad set of aims, including improving the quality of and access to care provided by 140,000 clinicians across the U.S., and specifically assisting those clinicians in moving toward and into successful value-based care arrangements. The UMass network included more than 1,600 optometry and ophthalmology practices, representing almost 4,000 individual clinicians. One of CMS' explicit goals for the program was to facilitate the entry of enrolled clinicians into advanced payment models, or APMs. Because there is no APM available for these eye care specialties, UMass, with CMS encouragement and approval, developed the APM under consideration here today. The committee members have reviewed and analyzed the model, and I won't present the model in detail during this short 10-minute presentation. However, at its core, as has been noted this morning, the model is very simple. It encourages and financially incentivizes eye care professionals to have a conversation with their established patients about the availability of urgent care services for ocular symptoms in the office or in the clinic setting. It further encourages the professionals to expand the availability of those services by expanding hours of service, by enhancing after-hours availability, and telephonic triage. Finally, this model takes an approach to reducing the use of emergency departments for non-emergent services that is far friendlier to patients and families than other interventions that have been recently publicized, such as retrospective denial of payment for unnecessary ED use, or triage models that redirect patients after they have arrived at the emergency department seeking care. I'll note that the one published reference that assessed the epidemiology and scope of the issue that this model addresses, ED use for non-emergent eye conditions, is based on data that are 10 to 15 years old. In the process of developing the model, we performed a very similar analysis to Chana et al., using the most recent years available from the same data set, NEDS, and found that there have in recent years, been approximately 3 million such visits each year, representing charges of about $3 billion annually for the 5 conditions covered by the model: conjunctivitis, corneal injury with or without foreign body, corneolum, acute posterior vitreous detachment, and eye pain. This is not a small scale or uncommon issue. I would also like to emphasize that this proposal is based on our experience in TCPI with over 1,600 eye care professionals. In that program, we were able to monitor the impact of these practices implementing the care model without any benefit from the financial incentives of a payment model. Even without any such incentives, the majority of the participating practices were able to implement the care model with minimal or no upfront investment of resources, and were able to demonstrate increases in urgent care visits that averaged 20 to 25% over baseline over the first year after implementation. Again, this was accomplished without the benefit of incentives. While the scope of the model is indeed limited to 2 specialties, we observed in the TCPI implementation secondary impacts that widen its scope. Optometrists have long sought and struggled to integrate their services more closely with primary care providers. Primary care providers are, in many cases, already engaged in more holistic, value-based payment systems such as ACOs and capitation models. And through those systems, the primary care providers are incented to control unnecessary costs. After reduction of hospital days, reduction of the utilization of emergency departments for non-emergent care is a prime target for such cost reduction. The ability of eye care professionals to contribute to the larger cost goals of ACOs and other networks serves to align and integrate these professionals more closely into the medical neighborhood and has a secondary effect of improving coordination of care. While difficult to measure, we did anecdotally observe this impact in the TCPI practices. Some of the concerns that have been voiced regarding this model relate to the level of risk assumption by participating clinicians in the form of the discount on fee-for-service reimbursement for urgent visits. These concerns have run in both directions. Comments from some individual clinicians and from professional societies have suggested that the 8% discount is excessive. Comments from the PRT questioned whether it is sufficient to truly meet the criteria for an advanced APM. In the spirit of Goldilocks, perhaps that suggests that we found the proper middle ground. However, we do acknowledge that if the model is broadly appealing, the discount level might be subject to further actuarial analysis and adjustment by CMS or other interested payers. In other words, the specific level of discount is a variable feature of the model and is subject to modification by any adopting payer. PRT members and public comments, including some of the discussion just minutes ago, reflected some concerns regarding the rather lengthy list of ICD-10 codes that are included within the model. We want to emphasize that this long list in part reflects the nature of the ICD-10 classification system. When we began model development, claims were still being submitted under ICD-9, and the list was actually much, much shorter by almost a factor of 10. But the diagnosis codes are used to reflect the payer perspective. And we fully recognize that patients present for evaluation and treatment based on symptoms, eye pain, red eye, blurry vision, et cetera. For this reason, we began our development process around the 5 common eye conditions that I've already listed. However, in order for payers to be able to effectively administer any such model, they need to be able to analyze claims based on diagnosis codes. And so we convened an expert panel of eye care professionals, chaired by Dr. Scott, who can answer questions about the panel. And that panel crosswalked the 5 conditions to the ICD-10 codes. The expert panel was instructed to include only those codes that are clearly and unequivocally within the scope of practice of both optometry and ophthalmology, and also unequivocally amenable to initial evaluation in an office setting. It was recognized that in some instances, these conditions might require referral to an ophthalmologist for surgical intervention, or even to an emergency department for emergent treatment. It was also a criterion that even in such event, a code would not be included if the additional step of initial evaluation in an office setting would introduce a delay that would pose a risk to the patient. In other words, the expert panel was instructed to exclude any code where the model might create a risk to patient safety. Codes were only included when the 5-member panel unanimously agreed that the code met criteria. We would like to emphasize that it is standard practice for optometrists to refer patients who present with conditions requiring surgical intervention to ophthalmologists. And as such, interventions are just not within their scope of practice. A typical practice makes such referrals multiple times every week. And the design of this model would not penalize them for doing so. If anything, the model provides incentives for eye care professionals to triage patients and provide or refer for appropriate care earlier in the progression of disease and without the need for a more expensive visit to an emergency department to get that referral. The financial incentives are modest and are hardly sufficient to motivate a clinician to jeopardize their licensure by withholding a referral or exceeding their scope of practice. So in closing, this model is designed to accomplish several goals which have been proven to be accomplishable in a large-scale pilot test of the care model: to provide a vehicle for a set of specialty practices to participate in value-based care, to reduce unnecessary use of emergency departments for non-emergent services, and to provide eye care professionals with new tools to facilitate closer alignment with the medical neighborhood and improve care coordination. While this model is specific to two specialties and a limited set of conditions, it is not difficult to envision its replicability for other conditions and other specialties. Eye care is hardly alone in the overuse of emergency departments for non-emergent care. This overuse has been the subject of extensive discussion in recent years in both the medical literature and in the broader media, and it's receiving a great deal of attention from private payers. We believe we have presented a relatively simple, novel, and elegant solution, which above all is patient-centered. Before I end, I would like to say that there are several things that came up a few minutes ago in the discussion between the PRT and the other PTAC members, and we would be happy to respond to some of those in the question period.
Great.
Thank you.
Thank you, Dr. Polikoff. I think what I'd like to do now is open it up to the PTAC committee members who would like to ask questions, and we can revisit the questions that we asked amongst ourselves, as you suggested. Each of the committee members, if you could just direct your questions to Dr. Polikoff, then he'll determine who on his team is best to go ahead and answer those questions. And just please, it might be a little awkward, but we'll see if we can make this work. So I'm going to go ahead and open it up to the committee members.
Jeff, this is Angela. I have a question, if I may.
Please.
So one point of clarity and one question. So one is, I think I heard you say that the patients were limited to established patients of the practice and therefore would not be taking patients who otherwise might be considering the emergency room and would call an office instead. Is that correct?
Thank you for that question. It's not so much that we limited it to established patients, but that is the only way that it was being promoted. The promotion of the model essentially was a communication between the participating clinicians and their established patients. Essentially, to make this very concrete, the practices provided flyers that were set on the reception desk and posters that were posted in the office that essentially said, did you know that we also treat urgent eye conditions? If you have an urgent issue, please call us. Here's our phone number. That in a nutshell is the promotion of the model. So while it is not closed to new patients, it's not promoted to them.
Thank you for that clarification. And my question around that is then, in the payment construct, how do you differentiate, or do you, patients that would have been coming to your office anyway for a number of these minor eye issues and would not have been considering the emergency room to begin with, and therefore really not decreasing an emergency room visit?
In the TCPI model, we counted as an urgent visit only those visits where the patient called and requested same day or within 24 hours of the call service. It was based on the patient's identification of a need for urgent service.
Okay, thank you.
May I follow up on that?
Bruce, you have a question? Go ahead.
Yeah, it's the same question I asked earlier, and it's a follow-up on Angela's. So I think we have a better understanding now of the population of patients that might change their behavior. But my question is still, what happens when the event that leads to a potential visit to the emergency room is late at night or weekend? is there's still the potential for that patient to receive office services, or does the timing of the event really dictate where the patient will receive the care?
Thank you for that question. There is still potential for that patient to be seen in the office. And to some extent, that depends on the individual practice's willingness to expand their services. Many of the practices that participated in our TCPI project were very small offices in small towns. The average practice size was 1.6 clinicians. And so in those instances, sometimes the doctors are willing to take the call in the middle of the night and come into the office. Or they'll say, you know, we open at 7 a.m. If you can be there at 7, I'll see you first thing at 7. But it really is up to the individual practice to determine just how broadly they want to open this up. In general, there's an element of telephone triage in many of these visits, both during normal office hours and even after office hours. And so, you know, it could be that the patient reaches the doctor through either directly or through an answering service, and the doctor ends up saying, you know, I think you need to go to the ED for that.
Thank you.
Grace? You might be on mute, Grace.
Can you hear me now? Got it. In a former life, I ran a large multi-specialty group that had ophthalmology and optometry in it. And I know that from that experience, quite often, one of the things, as you mentioned in your proposal, is true, that the equipment is actually better in the office than in many emergency departments, such that it's actually superior care, not just less expensive care. And quite often, when I've done urgent care work in the past and spoke to an optometrist or an ophthalmologist, they would meet the patient in their office and would not want to see somebody in the emergency room. So I perfectly understand where you're coming from with respect to this being potentially much better care. My bigger concern or questions are around the actual payment model itself, because this is essentially fee-for-service, which you have available now. And so I'm really more interested in understanding the barriers to why this type of urgent service is not being provided now by eye care clinicians, because essentially you could do this now. I mean, you could have extended hours. You could create some word of mouth. You could partner with primary care that were in ACOs to make sure that this, which is just a site of service issue and probably a more appropriate site of service in many instances, were done. So my biggest question for you is, if this is superior, which it quite often would be, what's preventing eye care clinicians from providing that service now?
I'll give an initial response. Thank you for that question, and then I'm going to ask Dr. Scott to comment as well. My distinct impression from interacting with these thousands of optometrists through the TCPI program is that it's more of a business issue related to the business model of their practices, and that's what we seek to interrupt with by providing a new payment mechanism. We should set optometry and ophthalmology apart in this part of the discussion because the services they provide are different and they're often reimbursed differently. But for the typical optometry practice, their revenue is a mix of clinical revenue and retail revenue from the sale of eyeglasses and contact lenses. And in most practices, the clinical revenue is actually a minority. And the reimbursement rates for fee-for-service visits, to be perfectly blunt about it, aren't sufficient to incentivize them to want to expand their hours, come in the middle of the night to see patients for urgent visits. They're more focused on the other side of the house. And so one of the things we're hoping to do is to in a very modest way, disrupt those incentives and provide an incentive to enhance the clinical services they offer. Dr. Scott?
Thank you. I agree, Dr. Terrell. I think this is it's a transitional time right now between fee-for-service and other payment methods that will be much more efficient and better quality for the patients. It exists already in certain venues. The VA, I spent a good part of my career in the VA, and it's exactly how it worked. Emergency rooms actually would, when they had patients who had eye conditions that weren't easy to manage, would call us in the middle of the night, and either we would go in to see them, or if it was a condition that could be managed, it was done that way. One of the interesting things that's happened recently is the acceleration of triage, electronic triage, telemedicine, telehealth, telephone that COVID has produced. And I got some data, I have some data that wasn't available when we submitted this, and that came from surveys that were done. New England College of Optometry and one of the large ophthalmology practices in Boston put together an ongoing continuing education weekly seminar for managing COVID, and it was available to optometrists and ophthalmologists. It became very popular. It was every 2 weeks, but the way they kept people interested in staying on the calls, where they had surveys, and two pieces of information came out that I was unaware of. One was a question about, during the pandemic, have you provided care to patients through by a required referral to required referral to a PCP, and 102 people out of 400, give or take, actually did that. And it sort of points out the value of triage. Instead of seeing somebody who has an eye symptom that manifests a systemic condition, the patient did get triaged correctly. And then the other one was for impact. During the pandemic, have you provided care for a patient? And that meant either telephone or, more likely, seeing the patient in the office of someone who would have gone blind if they hadn't been there. And it was about 100 out of 400 people who responded to that survey. So I think there's a reality check that desire to provide that kind of care is there. I would not have wanted to been on the panel reviewing this because of the complexity of it. I mean, it's very convoluted how you can incentivize people to do it. And I realize that having all of the ICD-10 codes has created a lot of confusion in the people reviewing it and the people observing it.
Thank you, Dr. Scott. Grace, did that answer your question? Can we move on? Yep. So my question is trying to wrestle the issue of scope. I commend the submitters for trying to get the eye care specialists on the field of value-based care delivery. I think it's a great effort on your part, and appreciate all the time that you put into developing this proposal. In the back and forth communication with the PRT, I saw that the TCPI program, and just sort of the global collective of practices you were working with, the urgent care visits that occurred in that initiative that qualified within the construct of this list were somewhere between, as you said, and this was all payers, and correct me if I've got it wrong, but 0 to 1, there was a lot of variability, but 0 to 1, over 25 what were classified as urgent care visits in a month. And that was with all payers. My concern or question is, is that in fact correct? And then if you look at this from a Medicare beneficiary standpoint, would there be sufficient numbers of members having these events that would make this a worthwhile effort for the eye care specialists to want to participate?
That's a great question. And I think that you've correctly identified that TCPI, while sponsored by CMMI, was an all-payer initiative. And the instructions of the program were to collect data on an all-payer basis. And so we did. I think the model becomes more viable the more different payers participate. And whether there would be sufficient Medicare-only patients in a practice to make the model viable and both statistically and financially is somewhat of an open question. I think it'll be highly variable among practices. It just depends on the patient base of a particular practice. I will say that part of that range of from 0 to 1 patients per month to 25, and that, by the way, that is per clinician, and that's not per practice, it's per clinician in the office. Some of that depends on the level of interest of the practice in expanding urgent visits. Most of our practices implemented the model, but they did so with varying levels of enthusiasm. And, so some of it is just who their patients are and who turns up and asks for care. Some of it is how active and engaged is the practice in promoting the model.
Okay, that's helpful. Again, if you really drill down and try and extrapolate the volume, clearly you'd want a model that would have sufficient numbers of events that would, as you said, sort of captivate the interest of the clinicians to make it worth their while, especially if you're talking about after hours or, weekends, et cetera, non-traditional hours. There'd have to be sufficient volumes to make it worthwhile, especially if you're talking about a reduction of the magnitude of 8%. And again, I understand that that's only for the visits in this particular category, but if there isn't enough volume and enough dollars attributed to that, it's going to be challenging to get the physicians and the clinicians activated to want to participate. So that's that's the thing that you guys are, that'll have to have further evaluation to be addressed. And obviously, as you've said, more payers that can participate, the higher the value of a model like this getting implemented.
If I may just add one other point, one of the things we found was that just anecdotally, was that the incentives that the participating practices said motivated them were not solely financial. The other motivation that came across as very powerful in talking to the clinicians and the owners of the practices was that it provided an opportunity for them to start to demonstrate how they create value in a value-based healthcare system. It allowed them to change their conversation somewhat in both the setting of negotiating managed care contracts, because they now had data on how they were creating value, and in developing their care coordination and referral relationships with primary care physicians. Once again, they used these data to demonstrate how they provided value, and which was something that previously they were really stuck and stymied. Everybody around them is engaged in a value-based care world, and they felt they couldn't participate in the conversation.
Great point. Thank you. Charles, you have a question?
Yes, and actually, I want to build on the last comment because you alluded to this model in the context of the medical neighborhood. And I'm just wondering, and you kind of alluded to that point there, but is this model more effective in a bigger context of a value-based organization, or are there ways that it would be enhanced by that context? So just trying to think about how being a part of the medical neighborhood, that this model would maybe be more more effective or enhanced. What are your thoughts around that?
Well, I can offer at least one illustration from the TCPI program. The TCPI was a broader program than just getting clinicians into value-based payment models or APMs. We also worked with the practices on improving quality, improving outcomes, and a whole range of other care coordination and care integration and patient-centeredness strategies. In the context of eye care practices, one of the ways that played out is that they do most of the eye exams that are measured in some quality measures, such as the diabetic eye exam measure, right? They do those measures, but primary care clinicians are accountable for those measures. And so we assisted these practices in their ability to electronically transfer data back to referring primary care clinicians that allowed the primary care clinicians to get credit for the eye exams that the optometrists had done. In so doing, that builds the relationship of the medical neighborhood. Right? A lot of these clinicians previously were in a world where they were sending a consult letter back by old-fashioned snail mail to the primary care doc, reporting on the eye exam. It never made it into the EHR. And as a result, the primary care physicians were reporting really poor results on their diabetic eye exams. We helped them fix that. That facilitates the relationship. Then we add on top of that this reduction of cost for unnecessary ED use, and the ability of the optometrist to display that back to the primary care physician is a way they're creating value. These things integrate in a more holistic way and start to enhance the medical neighborhood and essentially to bring eye care into the care team for the patient. I hope that addresses the question, Dr. Shazer.
Yeah, that's helpful, definitely. I see that capability in terms of the integration and coordination to support overall value-based strategies.
Thanks, Charles. Seeing no further questions, I'd like to personally thank the submitters for their time today, and more importantly, for their efforts to try and create a model for the committee to review and potentially be implemented. I'd like to just ask them to go back and they'll be moved back from the participant panel to the general audience. And they can return to a listening mode to continue with the meeting. We have two public commenters who are signed up, and I'm going to go ahead and work with the operator to call them up. The first is Dr. Stephen Ice. He's an optometrist from the American Optometric Association. Dr. Ice?
Hi, yes, can you hear me?
Yes, we can.
Okay. Yeah, thank you. Thank you for the opportunity to provide comments today. Again, my name is Dr. Stephen Ice. I'm a practicing optometrist in Southeast Pennsylvania, and I'm representing the American Optometric Association as a volunteer chair of the Third Party Center Committee. As background, the AOA represents approximately 39,000 doctors of optometry students, and para-optometric assistants and technicians. Doctors of optometry serve more than 10,000 communities across the country and counties that account for 99% of the U.S. population. Recognized as Medicare physicians for more than 30 years, doctors of optometry provide medical eye care to more than 6 million Medicare beneficiaries annually. In support of evidence-based healthcare and to serve the needs of the American public, the AOA develops clinical practice guidelines that meet the National Academies of Science, Engineering, and Medicine Health and Medicine Division, or NASEM, evidence-based standards. The aim of the PTAC proposal, how doctors of optometry can help reduce unnecessary hospital visits for eye emergencies, is such an important focus. As primary eye care providers, doctors of optometry have long played a role in serving their communities by providing emergency eye care. This role for doctors of optometry in the healthcare system has proven to be even more impactful over the past several weeks as our country has been faced with the COVID-19 public health emergency. According to data collected by the AOA, during the public health emergency, 79.2% of doctors of optometry surveyed were providing emergency care through the public health emergency. These doctors of optometry estimate that nearly 60% of patients they treated during the crisis would have sought care in an emergency department or other urgent care setting had they not been available to provide care. During the pandemic, reducing strain on overburdened hospitals was even more critical to our health system and to slowing the spread of the virus. However, even outside of the extenuating circumstances of the past few weeks, doctors of optometry can increase efficiencies in our healthcare system by caring for patients with emergency eye injuries to avoid unnecessary emergency room visits. Recent analysis have shown that an estimated $8.3 billion is spent each year on emergency department care that could be provided in another location. Additionally, nearly 40% of all ED visits were for non-urgent medical conditions, according to a 2013 study. Unfortunately, many patients are seeking care in EDs for ocular conditions that could be treated in an office-based setting. A 2017 study found that nearly 1/4 of enrollees who visited the ED for an ocular problem received a diagnosis of a non-urgent condition. Better educating and incentivizing patients to seek care for non-urgent ocular diseases in an office-based setting could yield yet considerable cost savings without adversely affecting health outcomes, and could allow EDs to better serve patients with more severe conditions. Further, a JAMA Ophthalmology 2019 analysis of data from an electronic record system found that patients with non-emergency eye concern would save $782 in charges and 5.75 hours in visit duration by choosing same-day outpatient care rather than an emergency department visit. It is clear that doctors of optometry can play a key role in achieving these types of cost savings. Additionally, the AOA's Health Policy Institute, or HPI, recently conducted a descriptive epidemiological analysis of the diagnosis codes reported nationwide in emergency department encounters, and determined that although urgent, most eye-related conditions reported in the emergency department may be treatable in an outpatient optometry clinic or office. The Agency for Healthcare Research and Quality, AHRQ, sponsors the Healthcare Cost Utilization Project, HCUP, a family of healthcare databases and related software tools and products. The nationwide emergency department sample is contained in a tool called the HCUPNet, useful for identifying, tracking, and analyzing national hospital data. Using the select set of eye and vision-related diagnosis codes, HPI queried the HCUPNet tool and identified a rate of 4.5 visits per 1,000 persons, totaling 1.45 million ED visits in 2016. The CDC reports a national rate of 458 per 1,000 persons in 2016, so eye visits represent approximately 1% of all emergency department visits in 2016. Potential savings by transitioning eye emergencies to optometry offices and clinics should be a key interest of healthcare payers and policymakers, most especially those shown by these data to bear the brunt of unavoidable eye-related emergency department visits and charges. These payers include private insurance, which is about 29%, Medicaid, which is about 40%, and Medicare, which is about 12.5%. For example, a 2013 study of 475,941 patients found that 91.5% of total costs, totaling $18.4 million, could be saved by diverting eye emergency department care to optometry offices and clinics. While we fully agree with the University of Massachusetts that patients are better suited to seek care for ocular diseases and conditions in an outpatient office-based setting with a doctor of optometry, we have concerns with certain aspects of the proposal. We fully recognize that as part of the alternative payment model, physicians must take on some financial risk. However, we are concerned that doctors participating in the model are required to take a discount of at least 8% applied to all fee-for-service rates on the emergency care-related visits. We know from previous research that there are significant cost savings when patients seek same-day outpatient care rather than an emergency department visit. We believe a more equitable model would be require doctors to pay an 8% payment penalty on pertinent visits in the year following the performance year, if savings were not truly realized. The care that doctors of optometry provide is valuable care, and we believe an upfront payment discount devalues that care. We are also concerned that the list of diagnosis codes meant to assist in the identification of visits that would be considered in the EyEDA model is too broad. The 2019 JAMA ophthalmology study indicated that the top 4 ophthalmologic diagnoses for ED patients were conjunctivitis, corneal abrasion, iritis, and vision loss. We recommend that the pertinent diagnosis code list for the proposed payment model be further revised and limited. We also believe for this payment model to be successful and equitable, there would need to be additional policy incentives in place. The policy proposal authors have rightly noted that patients lack awareness of the existence of alternatives to the ED for urgent eye care conditions. Hospitals lack incentives to dissuade or redirect patients with non-emergent conditions away from the ED. To assess these issues,
Dr. Rice, I don't mean to interrupt, but you're running a bit long. I've given you some added time, but if you could please close it out, that'd be greatly appreciated. Thank you.
Okay. Yep, I'm just about to finish. Thank you.
Super.
Okay. Yeah, we request that payers have a 24 phone line support service for questions for beneficiaries, and we believe the EDs themselves should be part of the effort to encourage patients to seek care with optometry offices. Without the engagement of other players in the healthcare system, the payment model would, in practice, target a single healthcare provider, which we believe may not meet the goals of PTAC. I also have a little exception with the characterization that optometry is very retail focused. Obviously, market forces have really pushed optometry away from that to where many of the practices are much more medically cared. And as a care provider, we just want to take care of our patients. Our incentive is to see our patients, to provide the care they need. We don't want to see them to go to the emergency room and get, care that may not address exactly what they need or be in their best interest. So again, thank you for your time. I apologize for running a little long, and I'll be glad to answer any questions related to care.
Thank you, Dr. Ice. I'd like to go ahead and turn it over to the next commenter, and that's Dr. Lori Grover, also from the American Optometric Association. Dr. Grover?
Good morning. Can you hear me?
Yes, we can.
Thank you, Dr. Baylett, and thanks to the committee for letting us comment today. I'm speaking a bit more today from a 30-year clinical background as a doctor of optometry, formerly with Johns Hopkins, and I also have doctoral training in health services research and health policy. I currently am the director of the Center for Eye and Health Outcomes at Memphis, and I wanted to just share with you that we understand and support the importance of the role of APMs in improving healthcare delivery. I do want to emphasize, I think it's important to view the eye care delivery role of the doctor of optometry as a parallel to that of family physicians within the healthcare arena, especially when you're taking into account the complexities of stakeholder incentives, payments, and delivery of quality patient-centered coordinated care. There's much to think about in that role. Doctors of optometry provide almost 80% of the primary care in the United States, and we understand the recognition of emergency eye care delivery as an area where cost savings certainly can be achieved. We recognize that primary care is really a primary access point to the healthcare system, and hence why I wanted you to have that perspective of us as a parallel to our physician colleagues in primary care. The observations made earlier regarding the suggested lack of clinical care volume in the delivery of primary eye care, they misrepresent the scope of the continuum of care that is delivered by doctors of optometry in the United States. And I think that's just because of observations limited to a small and narrower network that isn't really representative of current national continuum of eye care delivery, especially with Medicare beneficiaries. So aside from the data that supports this, I also can support this with personal experience. I've treated chronic vision impairment and have always served a larger, older adult population. So we embrace the area of emergent and urgent care, not only as part and parcel of what doctors of optometry deliver, but also as an area of great potential for transformational approaches. We support and appreciate the recognition of optometrists and their important national role in eye care. We value that greatly, and we feel it's time that we can help to take our place with our colleagues in that arena. The details that are proposed here, unfortunately, do require additional refinement and collaborative input. And ultimately, we aim to ensure that a wide range of clinicians that includes not only, as was mentioned earlier, both existing ACO and other network models in which doctors of optometry are engaged, but also can include small practices in rural areas where we can participate and have doctors benefit, have the patients that are served benefit, and have care delivery transformation that can be equitable and efficient. So thank you for letting me comment.
You bet. Thank you, Dr. Grover. I'm just going to check with the operator. Is there anyone else who signed up for public comment? Hearing none, I turn back to the PTAC committee. Are we ready to vote? It sounds like we're ready to vote. Since there's no other comments, I'd just like to review a few of the voting system parameters, which haven't changed. We're simply using an online version of the same technology that you've seen us use in typical meetings. We appreciate your patience as we use this tool virtually for the first time. It may take a minute or so to make the transitions and get people connected to the technology, but I just want to review some of the parameters of voting. We vote on first electronically on the 10 criteria. Member votes roll down until a simple majority has been reached. A vote of 1 or 2 means does not meet. A vote of 3 or 4 means meets. 5 and 6 means meets and deserves priority. If there's an asterisk, that means it's not applicable. After we vote on all 10 criteria, we will proceed to vote on our overall recommendations to the Secretary. We will use the voting categories and process that we debuted in December of 2018. We designed these more descriptive categories to reflect our deliberations for the Secretary. First, we will be voting using the following 3 criteria, or 3 categories. Not recommended for implementation as a physician-focused payment model, or recommended, or referred for other attention by HHS. We need to achieve a 2/3 majority of votes for one of these 3 categories. If a 2/3 majority vote to recommend the proposal, we then vote on a subset of categories to determine the final overall recommendation to the Secretary. And the second vote uses the following 4 categories, or subcategories, if you will. The proposal substantially meets the Secretary's criteria for PFPMs. PTAC recommends implementing the proposal as a payment model. Next, PTAC recommends further developing and implementing the proposal as a payment model as specified in PTAC comments. The third category is PTAC recommends testing the proposal as specified in PTAC comments to inform payment model development. And lastly, PTAC recommends implementing the proposal as part of an existing or planned CMMI model. We need a 2/3 majority vote for one of these 4 categories. So now let's go ahead and vote for the first criterion, which is scope, which is considered a high priority item. So scope, aim to either directly address an issue in payment policy that broadens and expands the CMS APM portfolio, or include APM entities whose opportunities to participate in APMs have been limited. Please vote. Audrey? Looks like can you go ahead, Audrey, and summarize for us what you see, please? You're on mute. Audrey, we're not hearing you. You're on mute.
Try again. Go ahead. Okay, can you hear me now?
Yes, we can.
Thank you. 0 members voted 6, meets and deserves priority consideration. 0 members voted 5, meets and deserves priority consideration. 0 members voted 4, meets. 1 member voted 3, meets. 6 members voted 2, does not meet. 1 member voted 1, does not meet. 0 members voted 0, not applicable. So we need a majority, which is 5 votes. And so the majority has determined that the proposal does not meet criterion 1.
Thank you, Audrey. Let's go to criterion 2, please, which is quality and cost, which is also a high priority designation. Anticipated to improve healthcare quality at no additional cost, maintain healthcare quality while decreasing costs, or both improve healthcare quality and decrease costs. Please go ahead and vote. Go ahead, Audrey.
All right. 0 members voted 6, meets and deserves priority consideration. 0 members voted 5, meets and deserves priority consideration. 1 member voted 4, meets. 7 members voted 3, meets. And 0 members voted 2, or 1 does not meet, and 0 members voted 0, not applicable. So the majority has determined that the proposal meets criterion 2.
All right, thank you, Audrey. We're going to move on to criterion number 3, which is payment methodology, which is also a high priority designation. Pay the APM entities with the payment methodology designed to achieve the goals of the PFPM criteria. Addresses in detail through this methodology how Medicare and other payers, if applicable, pay APM entities, how the payment methodology differs from current payment methodologies, and why the physician-focused payment model cannot be tested under current payment methodologies. Please vote. Audrey?
Are you ready?
I'm
Okay.
ready, Audrey.
All right. 0 members voted 6, meets and deserves priority consideration. 0 members voted 5, meets and deserves priority consideration. 0 members voted 4, meets. 0 members voted 3, meets. 4 members voted 2, does not meet. 4 members voted 1, does not meet. 0 members voted 0, not applicable. So the majority has determined that the proposal does not meet criterion 3.
Thank you, Audrey. Let's go on to criteria 4, which is value over volume. Provide incentives to practitioners to deliver high quality health care. Please vote. All right, Audrey. Please continue.
Okay. 0 members voted 6, meets and deserves priority consideration. 0 members voted 5, meets and deserves priority consideration. 1 member voted 4, meets. 6 members voted 3, meets. 1 member voted 2, does not meet. 0 members voted 1 does not meet, and 0 members voted 0, not applicable. So the majority has determined that the proposal meets criterion 4.
Thank you, Audrey. Criterion 5 is flexibility. Provide the flexibility needed for practitioners to deliver high-quality health care. Please vote. Audrey?
0 members voted. 6 meets and deserves priority consideration. 0 members voted. 5 meets and deserves priority consideration. 2 members voted. 4 meets. 6 members voted. 3 meets. 0 members voted. 2 does not meet, or 1 does not meet, or 0 not applicable. So the majority has determined that the proposal meets criterion 5.
Thank you, Audrey. We'll go on to criterion number 6, which is ability to be evaluated, have evaluable goals for quality of care, cost, and other goals of the PFPM. Let's go ahead and please vote. Here we go.
0 members voted. 6 meets and deserves priority consideration. 0 members voted. 5 meets and deserves priority consideration. 0 members voted. 4 meets. 7 members voted. 3 meets. 1 member voted. 2 does not meet. 0 members voted. 1 does not meet. 0 members voted. 0 not applicable. So the majority has determined that the proposal meets criterion 6.
Thanks, Audrey. Let's go to criterion number 7, which is integration and care coordination. Encourage greater integration and care coordination among practitioners and across settings where multiple practitioners or settings are relevant to delivering care to the population treated under the PFPM. Let's go ahead and vote, please.
Zero members voted. 6 meets and deserves priority consideration. 0 members voted. 5 meets and deserves priority consideration. 0 members voted. 4 meets. 3 members voted. 3 meets. 2 members voted. 2 does not meet. 3 members voted. 1 does not meet. And 0 members voted. 0 not applicable. As we've indicated, we need a majority, which is 5 votes. So in this case, a majority has determined that the proposal does not meet criterion 7.
Thank you, Audrey. Let's go to criterion number 8. Patient choice. Encourage greater attention to the health of the population served while also supporting the unique needs and preferences of individual patients. Please go ahead and vote. Audrey?
0 members have voted. 6 meets and deserves priority consideration. 5 members have voted. 5 meets and deserves priority consideration. 2 members have voted. 4 meets. 6 members have voted 3 meets. 0 members have voted 2 does not meet, 1 does not meet, or 0 not applicable. So the majority has determined that the proposal meets criterion 8.
Thanks, Audrey. And we'll go ahead to criterion number 9, which is patient safety. Aim to maintain or improve standards of patient safety. Please vote. Audrey?
0 members have voted 6 meets and deserves priority consideration. 5 members have voted 5 meets and deserves priority consideration. 1 member has voted 4 meets. 0 members have voted 3 meets. 5 members have voted 2 does not meet. 2 members have voted 1 does not meet, and 0 members have voted 0 not applicable. So the majority has determined that the proposal does not meet criterion 9.
Thank you, Audrey. And the last criterion, criterion 10, which is health information technology, encourages the use of health information technology to inform care. Please vote. Audrey?
0 members have voted 6 meets and deserves priority consideration. 0 members have voted 5 meets and deserves priority consideration. 2 members have voted 4 meets. 5 members have voted 3 meets. 1 member has voted 2 does not meet. 0 members have voted 1 does not meet, or 0 not applicable. So the majority has determined that the proposal meets criterion 10.
Thank you, Audrey. Audrey, could you just summarize where we fell out on the 10 criteria, please?
Yes. The committee has found that the proposal meets 6 of the 10 criteria, and that is criteria 2, 4, 5, 6, 8, and 10. And the committee voted that the proposal does not meet the remaining 4 criteria, and that consists of criteria 1, 3, 7, and 9.
Thank you, Audrey. We're now ready to move into the next section of voting, which is the overall recommendation. So you see here we have not recommended for implementation as a PFPM, recommended, which will require 2-part voting, or referred for other attention by HHS. Those are the 3 categories. We're going to go ahead and vote. Audrey?
So 7 of the committee members have voted not recommend. 0 committee members have voted recommend, and 1 committee member has voted to refer for other attention by HHS. In this case, you need a supermajority, which would be 6, and so the recommendation of the committee is to not recommend this proposal for implementation as a PFPM.
Thank you, Audrey. And in light of the vote not to recommend, there's no requirement to have the second stage of voting here. So I think at this point, we'd like to have the individual committee members make comments that can be embedded in the Secretary's report. And so what I'd like to do is, because it's virtual, I'm going to go back to the list of committee members as we used in opening for folks to introduce themselves and disclose any conflicts. So the first person on that list is Grace, and then we'll just go through the list, finishing with myself. Grace,
Excuse me.
Yeah.
Jeff, just want to confirm that as they do that they're going to indicate how they voted?
Correct.
Sure.
Thank you, Audrey.
Yep.
Thank you.
Yep. So I voted to not recommend, and mostly it was not about the care model, but it was about the payment model, which I did not think was adequate for the appropriate aims that they were bringing forth. I do believe that the ability to have extended hours and getting people out of the emergency department when there is a non-emergent but urgent eye problem is appropriate, and it was thoughtful, many of the ways that they put together their proposal as it relates to that. I did not think that the payment model that was proposed would get them there. And so I think there's some others that might be thought through, which is about other ways of motivating people to have increased access. Part of my concern was the need based on numbers for it to be about more than just Medicare, and I like the idea that in the original CMMI it was an all-payer access, but I wonder if care coordination fees, other types of bundled payments, many of the other types of payment models that are out there would actually achieve their aims better than a discount for volume. So that's sort of where I voted and why I voted the way I did.
Thank you, Grace. Paul?
Yeah, hi. Yeah, I also voted to not recommend. Similar thinking to Grace. I mean, it was really the payment model, I think, was where I think there was most challenging. I do think that, as Grace just said, increasing access, appropriate sites of care that are lower cost, better equipment in the office, all those would achieve higher quality. But I think that the payment model is currently described being sort of office-based payments. I don't think, I think there's other ways of doing that. And I still struggle with the scope. I mean, I understand that optometry, the eye care physicians haven't specifically have had a model, but it seems to me that this is one that can be embedded in broader models effectively, and I would see that coordination with primary care would benefit both, and of course benefit the patient.
Thanks, Paul. We've got Charles next.
Yes, I would just echo the statements of Paul and Grace, and that the elements that I struggled with were the scope and the payment model. And those are two high priority criteria for us, which this model fails on. But again, I think that there are elements that, if you embed it within a bigger context, could be of value in terms of the role of this strategy. So that I voted to not recommend on that basis.
Thank you, Charles. We have Kavita followed by Angelo. Kavita?
I voted to not recommend, and the only thing I would add to be included in the Secretary's report is some comment regarding how best to carry forward outside of a CMMI model what was learned and gained from the TCPI program in particular, because of the ability to demonstrate this type of practice transformation is important to find a home for within kind of the HHS enterprise.
Thanks, Kavita. Angelo?
Yeah, I'll echo a lot of just what's been said. I did vote not to recommend. My main concerns were the scope and the number of diagnoses automatically listed there, and also very much the payment model. And I'd also echo, I think there's a lot of value otherwise in this model in terms of being able to provide high quality care outside the ER, sometimes when there is actually much better equipment, but maybe better suited to be integrated into more of an integrated model with a delivery system and a robust triage and referral system.
Thanks, Angelo. Bruce, followed by Jennifer.
I agree with the comments so far, especially about scope and the payment model, but I was the one person that voted to refer because I like to be different. But the reason I did that is because I was persuaded by some of the proposers' comments about telemedicine and the potential for telemedicine to be a source of both triage and referral and care coordination for the population. And since that's a high priority that Secretary Verma mentioned, I thought it obviously could be covered in the discussion section of our report, but to identify this as a potential good area for the application of telemedicine.
Thank you, Bruce. Jennifer?
Yes, I too voted not to recommend. It's obvious that current payment models don't encourage broad access to subspecialty eye care as was described, and the TCPI project had impressive results. However, given the current proposal, I too shared the concern that the payment methodology would not garner participation of providers or participants as currently described, which then directly impacts a high priority area of scope. The other thing I would add that has not come up in this conversation is the issue with regards to patient safety. And my comment would be that the patient safety metrics described in this proposal are ones that don't appear to crosswalk to what is standard complications related to these ambulatory sensitive conditions, specifically those of observation, inpatient visits, and deaths. So it appears that those quality metrics are a mismatch to what's being described. And I agree with one of the previous speakers that a global period that extends far beyond 7 days, if this were to be considered, is more appropriate. Thank you.
Thank you, Jennifer. And I also voted not to recommend and agree with the comments that have been made. The only other comment I would make is an earlier observation about the numbers of encounters that qualify when we're looking at a small number, 0 to 1 per doc, per clinician per month that would qualify. I'm just concerned that there would be insufficient scope. I do commend the submitters for trying to engage and get the optometry community into the value-based world. I commend that effort and think that more thought needs to be placed on how to get a model out that this specialty could participate in to get into a value-based care delivery more than they are today. So that was closing out those comments. I think it would be good, Audrey, if there could be a readback of comments that the committee made, just to ensure that we were articulate and that those were captured, to go ahead and embed those comments into the Secretary's report. So someone on the team want to summarize what they heard or ask any clarifying questions? Yeah.
We'll turn that over to Sally.
Right. Thank you.
Okay. So let's see. To summarize, what I want to do is start with some of the positive points that were made, especially about the care model. That historical data show that a large proportion of ocular-related visits to the ED often could be appropriately treated in an office-based setting, and in particular, offices may be, in many cases, better equipped than EDs for some of the ocular problems. Also, the report will emphasize that the TCPI experience showed interest and ability of many practices, including small practices, to expand their clinical services for the 5 categories of conditions identified. And also the COVID experience over the last few months, although not part of the proposal, has further emphasized the value of virtual and office-based services for ocular conditions that can be appropriately be treated in an office-based setting. Okay, however, the report is also going to pay particular attention to the concerns on the 4 areas where the voting did not support the model. That would be scope, payment, integration and care coordination, and patient safety. And some of the specific comments there include the fact that the payment model, that the PTAC does not feel that the payment model will get them to the point of being able to really encourage practices to move these services, that there's a need for other ways to get people to do this, and including attention to broader care, broader models such as ACOs or alternatives such as bundle payments. Some of the other points and concerns include, Jennifer mentioned some patient safety concerns, and the broader problem that the current payment models from CMMI often don't encourage broad participation by optometrists, but simply that something broader is needed. And I will also fall back on some of the comments in the PRT report on those specific 4 areas where the voting was not supportive of the model.
Thanks, Sally. If there are no other comments from the committee members, we have completed the first deliberation of the morning session. We are reconvening at 12:45. At that point, we'll have Brad Smith from CMMI provide some opening remarks. I am on the second PRT, so I'm going to turn the gavel over to Grace at that time so that I can fully participate as a member of the PRT. So we are going to end this session. I want to thank the commenters. Also, more importantly, want to thank the submitters for their time and attention developing this proposal, working with the PRT, and providing their input today. And also all of the members and stakeholders across the country who participated in the session this morning. We're going to go ahead and adjourn until 12:45. Thank you.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.